Okay, so now we're going to talk about the management of total colonic aganglionosis. So we're going to discuss two scenarios. Number one is the ideal scenario. You suspected total colonic aganglionosis because you have done a contrast enema and you saw that shape that the patient loses the splenic and the hepatic flexure. It's a more rounded. You don't see a clear transition zone. Irrigations are not very productive. So you are really suspicious that this could be a total colonic aganglionosis. You have done your rectal biopsy, so you know it is for sure Hirschsprung, because in all patients, the rectal biopsy will be abnormal. So in that scenario, you can take the patient to the OR, take leveling biopsies, and perform an ileostomy. We prefer divided ileostomy, so we are not feeding the distal bowel with stool. The second scenario is that you thought it was a classic Hirschsprung. So you may have started the transanal dissection if you're thinking about doing a primary pull-through. Hopefully after Dr. De La Torre's lecture, you are discouraged on that path. Or you were just suspecting it was a simple Hirschsprung and intraoperatively you found, but if you have already started the dissection, then we would recommend that you do an iliorectal anastomosis and an ileostomy higher up. But if you are in the ideal scenario where you just did the ileostomy, then our next step will be the colectomy with the iliorectal pull-through. Depending on your experience, depending how you see the pull-through, you can decide if you need a protective ileostomy at that stage or not. It also depends on the age of the patient, your local circumstances, and as I just mentioned, the quality of the surgery. But in the common scenario, the baby will be with an ileostomy for a while. So ileostomies, we have to be sure that the patient is not having large outputs. So we have to manage how much is coming through the ileostomy. And we always measure the urinary sodium. So every time the patient comes to clinic, we tell the mom to put a cotton ball near the diaper where the baby pees. If it's a boy, obviously close to the penis. If it's a girl, close to the urethra, so we can catch that cotton ball filled with urine, and then we're going to measure the urinary sodium. Most patients will need oral sodium supplementation that helps them grow, because with an ileostomy they lose a lot of salt. There is the sodium glucose pump, so once you give them oral sodium, then they are able to grow better. So we always prescribe oral sodium, and we start with 1 mg per kilo twice a day. Then we measure after 1 month. It's normal when it's above 20. If it's below 20, the patient needs supplementation. If you have started supplementation and it continues to be below 20, it means you have to increase. So now you're going to go to 2 mg per kilo. And usually that's enough. Now, once the baby has the ileostomy, the baby is very happy, is growing. Remember, babies are not aware of their surroundings. So if they have an ileostomy, they think that this is normal life. Our condition to close this ileostomy is that the patient is toilet trained for urine. They can verbalize and make it to the toilet, and the patient accepts rectal irrigation. Remember that the longer the segment of Hirschsprung, the higher the chance of enterocolitis. So in patients with total colonic aganglionosis, it's expected that you will have postoperative enterocolitis. I know enterocolitis is probably not the perfect name because technically we don't have the colon, but it's the manifestation of the same disease. So, and the treatment is rectal irrigation. So, in order to truly know if the patient accepts rectal irrigation, I ask parents to demonstrate in clinic. The reason is, if you're going to have an anastomosis very fresh, and we're going to have to do rectal irrigations fresh from a post-operative, you really don't want a child that is jumping, that we have to hold, that we have to force. We want a child that trusts the process, can lay down and let you do it. And if the patient is not ready, then the patient is not ready for the pull through. It's very important that parents understand that. Why we don't recommend an iliorectal pull through in a baby. Dr. De La Torre just mentioned, it's not that we can't do. Of course we can do. The problem is when the patient loses the colon, the patient will have the small bowel connected to that short piece of rectum, so basically near the anus. And you have to remember that the small bowel has a very fast motility. And babies, all of us, when we are born, we don't have bowel control. Bowel control is something that comes with time. So if we connect the ileum to the rectum, the baby will have multiple bowel movements and terrible diaper rash. The quality of life will be miserable for that baby and for parents. And there is no cream, there is nothing we can do to help that because bowel control comes over time. Now, if we are doing an iliorectal anastomosis in a patient that has bowel control, that knows how to feel and go to the bathroom, yes, in the beginning, they will have several bowel movements. They may have 10 bowel movements, but they can make to the toilet. So they don't have diaper rash. So we are talking about quality of life. Total colonic aganglionosis is a rare disease. Most surgeons don't have very large series. So if they have done one patient and they send the patient away to gastroenterology, and the nurses are the ones managing all the drama from the family and the suffering, the surgeon doesn't know, and they think they were very successful. We follow our patients for life, so we stay with the patient, and we truly believe that the best approach is to wait until the patient is toilet trained. Quality of life is much better in that way. So the key message again for total colonic aganglionosis: protect the anal canal. In a patient with total colonic aganglionosis, if you damage the anal canal, there is no treatment we can offer. This patient will need a permanent stoma. This is a very important message. So same thing, if a patient has the most common type of Hirschsprung, the rectal sigmoid, we also don't want anyone to damage the anal canal. But if the surgeon damages the anal canal, we still have enough colon that we can offer bowel management with enemas and keep the patient artificially clean in the underwear. Unfortunately, enemas are not for the small bowel. The function of the small bowel is to absorb nutrients. So we cannot do bowel management in the small bowel. Bowel management is only enemas, is only for the colon because the colon does not absorb nutrients. So we can clean the colon and keep the patient artificially clean. We cannot clean the small bowel, and the small bowel has fast motility. It has constant nutrients and food inside. So if you damage the anal canal in a patient with total colonic aganglionosis, this patient will need a permanent stoma. So I know Dr. De La Torre already saw it, but this is honestly the most important message. So I'm going to show again. This is a normal anus, and you can see this smooth area. That's the anal canal. That's where all the sensation is. That's where the patient can differentiate from solid gas and liquid. And then you see here the rectal mucosa. So when we do a pull through, you have to advance the hooks and protect the anal canal completely. Start our dissection. I do it 1 or 2 centimeters in the rectal mucosa, in the rectum, and then we want to do the anastomosis again 1 to 2 centimeters, protecting completely the anal canal. So this is a case of total colonic aganglionosis. The patient had an ileostomy at birth. Then she met criteria. She was accepting rectal irrigations and she was toilet trained for urine. Therefore, we offered the iliorectal pull-through. So here you can see the patient is in prone position, face down. We have the Lone Star hooks protecting the anal canal completely. And we place our 5/0 silk stitches 1 centimeter in the rectal mucosa. So we're gonna start our dissection. So here you can see all the anal canal is preserved. We still have this amount of rectum. We started the dissection. Here is the entire colon. And here we brought the ileum and we're gonna do the iliorectal anastomosis. So this patient, so now you can see that the anal canal was completely preserved. We still have rectal mucosa. This is the ileum. And this patient, she's now more than 10 years old and she has approximately 4 bowel movements per day and bowel control. So what's our post-operative protocol? Once the patient, if we do like in this case that I just showed you, that we do an iliorectal anastomosis, no protective stomas, I keep the patients in the hospital 7 days, nothing by mouth, receiving TPN. Some patients, they do well and they start stooling during those 7 days. Other patients, day 4, they get distended. And that's when we get an x-ray. And if we see that there is gas in the bowel, we're gonna start the rectal irrigation. And the first one has to be done by the surgeon because the anastomosis is very fresh. But even if the patient was doing very well, once we start feeding, I send my patients on prophylactic rectal irrigations. And the protocol is 3 months. So in the first month, they do 3 rectal irrigations a day with flagyl, metronidazole, 3 times a day. If they are doing well, second month, we go to 2 times a day rectal irrigation and flagyl 2 times a day. If they are doing well, the third month, they should do once a day rectal irrigation, once a day flagyl, and at that time, they should be stooling spontaneously in order for you to stop the rectal irrigation. At 1 month, they come to clinic, I do a digital examination. If I can feel the line of my anastomosis, I start the protocol of anal dilation. Sometimes it heals so nicely that you don't feel that line, then you don't need anal dilation. So that's the protocol. I'm gonna stop sharing my screen because, can you hear the sound, Ray?
No.
Okay, 1 second. I'm gonna stop sharing.
And just 1 second, I'll get that out.
And then Ray is gonna show this video on how to do rectal irrigations. And again, the reason why we are talking so much about rectal irrigation is because we feel this is a very important treatment modality for Hirschsprung. Okay?
Children born with Hirschsprung disease often suffer from enterocolitis. The best method for treating this condition is by flushing and emptying the colon with fluid, which is called rectal irrigation. You'll need the following supplies in order to perform a rectal irrigation: 2 small basins, a 60 milliliter syringe with catheter tip, and a silicone catheter. If your child is under 1 year old, a size 16 French Foley catheter should be used. And if your child is over 1 year old, then you'll need to use a size 24 French Foley catheter. You'll also need water-soluble lubricant and normal saline. Start by warming the normal saline. We recommend sitting the bottle in a sink of warm water, then testing the temperature of the saline on your wrist to make sure it isn't too hot. Pour the warm saline into a small basin, then draw up 10 to 20 milliliters using your catheter tip syringe. Position your child so they are laying on their back with their knees bent to their chest, or if they are bigger, with their knees bent with feet flat on a surface. Place the empty basin next to your child. Lubricate the top 2 inches of the tip of the catheter and insert it into the rectum. Gently push the catheter so it follows the curves of the colon. Insert the catheter approximately 4 to 6 inches. Pause for a moment to allow any stool or gas to drain out the catheter into the empty small basin. Connect the syringe to the catheter and inject the 10 to 20 milliliters of saline. Disconnect the syringe and let the saline and any stool drain into the empty basin. Advance the catheter about 1 inch and repeat the process until the discarded fluid is clear. Do not advance the catheter further than the wide divider port. It is important between each injection that fluid drains into the basin. If the amount of saline you inject into the rectum is more than the amount of fluid that returns to the basin, then there is extra fluid in the rectum. To drain the extra fluid, try moving the catheter in and out while twisting. If fluid still does not come out, then the catheter may be clogged. Pull out the catheter and flush with saline into the basin before reinserting. If you think there is still fluid in the colon, you can reattach the syringe to the catheter and very gently pull back on the syringe to draw out the fluid. Do not pull back on the syringe if you feel any resistance. It's important to record the amount of saline injected into the rectum and the amount of fluid that comes out. In a good rectal irrigation, the amount that comes out is larger than what went in. Once the drained fluid is clear, remove the catheter from the rectum and wash your supplies with soap and water, then set out to dry. The supplies are reusable.
So this is the classic image of patients with enterocolitis that you see a very distended bowel filled with gas. And this is before the irrigation. This is after irrigation. Here's another patient. This is a patient with not total colonic aganglionosis. This is a patient with classic Hirschsprung, but you can see that there is a very distended filled with air colon, and after the irrigation, we have a significant improvement clinically and radiologically. And this is the worst diaper rash that we have ever seen in a patient with total colonic aganglionosis in which the anal canal was damaged. This boy could not even sit down because of pain, and they came to us with the hope that we could offer some diaper creams or bowel management. And it was a very difficult discussion because the only treatment we can offer in this case is a stoma.